So, with due permission, I start this topic. I think it is a neglected topic because we do angioplasty, we see individual patient, but we should also see a group sometimes also. Group CAD and group wise. So last time we did thesis on elderly females, then last year we did thesis on young males. So this time I allotted topic on perimenopausal females because I noticed in cath lab that many young females are having this ACS and their angiographic pattern were not benign. They have very complex pattern. So when I allotted this topic, my PG was a little bit hesitant. He said that, oh, we will not get many cases. I told him, let's see. And you will not believe me, in a period of 4 months, I could get as many as 70 cases who are of young females and very complex pattern of angiography. What we think theoretically they are benign disease, I don't think they are at all. So let's see this case, the young 30-year-old female who presented with the atypical symptoms, more like postprandial angina, and she had no other traditional risk factor except hypothyroid. And she had acidity and atypical chest pain, but ECG had flourished anterior wall MI, and then troponin was very high, BNP was high, and echo was very much suggestive RWMA in LED territory, EF was 40%, LDL was slightly raised, and HSCRP was raised, and mild rise in homocysteine and lipoprotein. And this is the angiographic pattern of this female. Now, we see this, that is whole LED, and she's only 30-year-old, and there was no family history, no family history and nothing, and she has still LED cutoff. And then we find this pattern that is a complex, and she would have collapsed if she was not taken in the cath lab, and a successful angioplasty was done. So this is one example that because it is very challenging to diagnose CAT in young females because of the atypical pattern and because of their silent ischemia and atypicality, which is confused with GERD. So this is a successful angioplasty which was done in this case. And there are so many cases which I will highlight in between the presentation, because we know that is in young perimenopausal female, basic etiology, angiographically pathophysiology is plaque erosion. But I could find many complex angiographic pattern also. This is a young female with a proximal LED. There was a thrombus, a spiral eccentric thrombus, and she's 35-year-old, and she had a history of recurrent abortion. There's only one clue, the recurrent abortion, and she was having chest pain and a strongly positive EPLA. That is, she had high titer of antiphospholipid antibodies from and recurrent abortion. So this was the one risk factor which was responsible for her ACS. So this was a very interesting case, and then the time is not permitting me to tell about the follow-up of this case, and then we proceed to the next case. Now this is a 30-year-old female, not many risk factors except hypertension and triple vessel disease. You see mid L6, and that is the CTO is there, and RC, mid RC is the tubular lesion maximum 99%. So we think that perimenopausal women have only plaque erosion, single vessel disease usually, but in cath lab we see they have complex pattern also, and they are not rare. They have triple vessel disease, they have diffuse lesion, they have calcific lesion, they have aneurysm also, type C lesions also. So maybe we are underestimating them, or maybe the scenario has changed in last 10 years because of the high prevalence of traditional risk factors and overall added with the newer risk factors. This is 45-year-old female showed proximal involvement, proximal LED and LCX along with aneurysm. There is diffuse LED involvement. Diffuse LED involvement is there, right from distal left main, ostial LED proximal to distal LED and aneurysmal involvement, and then the collateral is going to RCA, retrograde filling of RCA. And she is also perimenopausal. And there was only one risk factor, that the hypertension. This is 35-year-old female who was on high intensity statin after a PTCA duality, and then she developed chest pain, and she showed that is a discrete, very tight lesion in LCX. And then another vessel has to be tackled, that is mid LCX show, that is before the bifurcation. There's a 95%, and then PTCA2 LCX was also done. And yesterday I did a case angiography where she was a 40-year-old female. She was diabetic and she has multiple lesions, 2 lesions in LED, and she has RC also. She required 3 or 4 stents to tackle it. So problem statement is coronary artery disease in women is underdiagnosed, under-recognized, undertreated with BICE approach, and is one of the leading cause of death, cardiovascular death in women in postmenopausal and even in younger female, situation is not so benign. Asian Indian women are higher, CAD rate are higher as compared to the other ethnic origin. Although CAD rate among women have reduced to half in West for last 30 years, but it has doubled in India. So the clinical feature of ACS in young female, are they different from postmenopausal women? We know there's always a hormonal protection cover of 10 years, but once this cover is lost, postmenopausal, they catch up and they become the incidence, prevalence, and all the presentation, they become almost similar to the male counterparts of similar age. But young female presentation are very atypical. There can be silent ischemia, there can be without chest pain, they can be atypical presentation, very difficult to suspect and very difficult to pick up, and not to miss a single case of CAD in young females, especially in the absence of risk factor where there is no clue, where ECG is not helping us, how to go further, how to confirm whether you require angiography or not, because TMT is usually false positive, and it is your clinical clue and it is your only experience most of the time which guide us whether we should proceed further with do CT angiography or do bitumen stress test or take up directly for angiography. And we will not be surprised when traditional angiography show very lethal lesions, or there very important lesions are there which require urgent attention in the form of revascularization. And one of the most important pathophysiology in young female is plaque erosion. Unlike plaque rupture and different type of lesions which are found in postmenopausal female. And atherosclerosis as such has the sex predilection, and male versus female. One example is carotid stenosis, although it is more frequent in male, while the risk of stroke is higher in women. Males show greater protective effect after carotid endarterectomy and lower perioperative stroke and mortality, but women have a long time higher risk of a stroke, and more likely the stroke is cardioembolic, and male usually have lacunar stroke. Similarly, for heart failure, women are more prone to have heart failure, repeated hospitalization, and most of the time, etiology is preserved ejection fraction type of heart failure. Morbidity, mortality is higher. Short term and long term, they are comparable with males. But women are less likely to have CAD as a presumptive cause of heart failure as compared to males. So sex is playing definitely a role in presentation of atherosclerosis beyond CAD, as far as carotid circulation is concerned, as far as heart failure is concerned, as far as this another example is abdominal aortic aneurysm, which is 4 to 6 times more common in males. But women take, if women is having abdominal aortic aneurysm, it has higher risk of rupture of aneurysm and higher morbidity even after surgical repair. Here, women, they are high risk of rate of expansion of aneurysm per year and risk of impending rupture even after surgical repair. They do poorly as compared to males who have repair of abdominal aortic aneurysm. It has been shown that after menopause, women are no longer protected by hormones, and risk of abdominal aortic aneurysm is also increased, which is another presentation of atherosclerosis. And similarly, it goes for many other diseases, such as peripheral artery disease, which is also more common in females, and usually they're asymptomatic or atypical. There's no typical claudication as compared to males. So list is endless, where there difference not only in the presentation, but in incidence, in prognosis, short term and long term, how they perform after the procedure, after revascularization, even the response to the treatment is different in males and females. And it is also different in females pre versus postmenopausal females. So traditional risk factors, if you say elevated blood pressure, diabetes, obesity, and dyslipidemia, these are traditional risk factors. But two risk factors, they have particular prediction for females. One is prolonged smoking, and another one is that is diabetes. These two have a specific, more magnified effect on CAD in women as compared to men. And sex predilection in females are with the smoking, diabetes, and bed obstructed history. This one risk factor is totally neglected by most of the guidelines, because it is one clue where we have to pick early, and we have to screen the young female, especially with history of bed obstructive history, to look for cardiovascular disease or risk of future vascular event. As far as one risk factor and future CAD is concerned, the relation is unilinear. But when there are two or more risk factor in male versus female, in female, it has been seen clustering of two or more risk factor in female amplifies the problem and make it more complicated and more magnified as compared to males. This chart showed CAD males, females with and without hypertension, and so as the age advances and female crosses menopause age, and they become comparable, number become comparable with male counterparts. So sex predilection is especially there in three. I will say one is diabetes, where there is a traditional diabetes, type 2 diabetes, or just gestational diabetes also. Other is smoking, and third one is bad obstetric history. So highest risk category in females are clinically manifested CAD, cerebrovascular disease, peripheral artery disease, abdominal aortic aneurysm, CKD, diabetes, early menopause, and 10-year predicted CVD rate more than 10% and high inflammatory markers. So this hypertension, we know, hypertension very common factor. It plays a special role in female, especially if a female have gestational hypertension or hypertensive disease of pregnancy associated with eclampsia, preeclampsia, then definitely the risk is very much amplified. And pregnancy-related hypertension, you see, it is found in 2 to 10% of cases. Diabetes confers greater risk for CAD in women as compared to men, especially women with type 1 diabetes had twice the risk of fatal and non-fatal cardiovascular event and 40% greater risk for all-cause mortality compared to male. And diabetes screening for women and men over the age of 45 years and every 3 years has been suggested by American Diabetes Association. For women with history of gestational diabetes, screening for diabetes should occur 6 to 12 weeks postpartum, and then lifelong testing every 3 years. Even if women doesn't become overtly diabetic after gestation is over, then also this gestational diabetes factor definitely weighs to future CAD risk. And you know the incidence of gestational diabetes is 3 to 5%. And these gestational diabetes or diabetic, they're associated part of obesity, polycystic ovarian disease, PCOD, metabolic syndrome, overweight. So they come with a package. Dyslipidemia, there's a virtuous, that is a relation of dyslipidemia in peri and postmenopausal women, and especially triglyceride are high, VLDL are high, but HDL is 10 milligram higher in female than compared to male. But the high level of HDL does not correlate to protective outcome as far as the future CAD events are concerned, although it is said to be protective. So adverse changes in lipid profile accompany menopause, and then definitely there is a rise of LDL triglyceride and decreased level of HDL-C. So cigarette smoking, based on 2018 data, 16% men and 12% women reported tobacco use. Although women smoke less than male, but smoking cigarette may be detrimental more in women than in men. Female smokers are supposed to die 14 years earlier than female non-smokers, and smoking actually causes down-regulation of estrogen-dependent vasodilation of endothelial wall, and the protection which was provided in a premenopausal stage by estrogen is lost by smoking. And there's 25% or greater relative risk of CAD in female versus male, especially those who are smokers. So somewhat the protective effect of estrogen is lost by smoking. Then pattern of obesity is also related to CAD and just a part of metabolic syndrome. Obesity is not an independent factor of CVD, given that obesity is strongly associated with many of the traditional CAD factors. So we can say it is a surrogate, and especially if obesity is combined with physical inactivity in perimenopausal age group, it becomes a very important risk factor. Family history, especially if the father has documented CAD or ACS before the age of 65 years, or mother has before the age of 55 years, and mother has below the age of 65 years, then definitely family history is said to be positive. Another important is a this is high level of inflammatory marker, and which we do commonly is HSCRP, more than 2 or 3 times raised. It is also said to be a ACVD risk enhancing factor. Although measuring HSCRP is not recommended in routine risk assessment in women, but rather an option those persons who are at intermediate stage based on ASCVD score. Sex-specific risk factors are polycystic ovarian disease, which is associated with metabolic syndrome, high sugar, and insulin resistance. And nevertheless, it is still unclear if PCOS can be taken as an independent risk factor for premature CAD in women, but definitely it plays a role. It comes as a package of metabolic syndrome and insulin resistance and diabetes. OCP, women who are smokers, especially over the age of 35, uncontrolled hypertension, history of DVT, history of CAD, they have unacceptable level of CVD, especially if they're associated OCP. So always a history of OCP should be asked in young females who develop evidence of some arterial or venous thrombosis or who have ACS in early life. Then OCP becomes very important in history, and every young female should be especially asked whether she was taking OCP or not. Gestation diabetes increase the risk of CVD, and this pooled analysis, 9 studies have demonstrated that women with gestation diabetes twofold greater risk of cardiovascular event in first 10 years postpartum compared with women without gestational diabetes. And there's 3 times risk of CAD. Relative risk is 2.82 versus 2.16 in males. And relative risk of CAD is 44% greater in females versus males. So premature menopause, yeah, this is very important point. That is those females who have early menopause, that is below the age of 45 years or as early as 40 years. You imagine these females, they spend 40% of their lifetime without the cover of hormones, without the protective cover of hormones. So they're very high incidence of CAD. So why not it should be taking as a early menopause as a risk factor of CAD. Still now it has not been given its reputed place in the guidelines whether early menopause transition point should be taken as a very strong risk factor for females that they have a future vascular event. And premature ovarian insufficiency differs from premature menopause. It is defined as ovarian failure before the age of 40 years, resulting in prolonged exposure of estrogen deficiency. And this premature ovarian insufficiency is moderately associated with increased incidence of coronary artery disease. So menopause can be artificial, menopause can be surgical, that is natural. So natural is better than artificial menopause, where even ovaries are removed because of some condition and patient is totally bereft of protective effect of estrogen. Then another added factor which plays very important role is breast cancer. And breast cancer patients, they have shared risk factor between breast cancer and CVD, in addition to potential of direct cardiovascular injury that may accelerate atherosclerosis or heart failure. Apart from chemotherapy and radiotherapy, especially the role of anthracycline and monoclonal antibody, which increase the risk of heart failure and repeated echo has to be done. Ionizing radiation during radiotherapy for breast cancer also increase the risk of CAD abiogen. So this is directly proportional to mean radiation dose to the heart. So this bad obstetric history, every patient should be asked about. Premature delivery, preterm delivery before 37 weeks of gestation, which is usually known to complicate 11% deliveries worldwide. There is a strong association between preterm delivery and maternal risk of coronary artery disease. Even if the female is all right, mother, but the fetal and placental complication in the form of IUG or a placental insufficiency, then also such female has high relative risk of 2 to 4 times of CVD. So gestational hypertension of any time, any type or associated increase of hypertension, CKD, diabetes, stroke or CVD. Hypertension during pregnancy is recognized as risk enhancing factor by 2018 guidelines on the management of blood cholesterol. Antiphospholipid syndrome is another heterogeneous group of antibodies directed against the protein that bind phospholipid to some antiphospholipid antibodies, and this can promote arteriovenous thrombosis and placental thrombosis. And they can be cerebral vein thrombosis, or they can even lead to fetal loss before 10 weeks of gestation, unexplained fetal death after 10 weeks of gestation. So EPLA becomes a strong risk factor for ACS also, and such females, especially if you are dealing with CAD in that group of female who are reproductively active, EPLA panel should always be asked, because this is one risk factor which will guide us to give aspirin in high risk pregnancies to deal with EPLA and to avoid abortion and also protect heart. So this antiplatelet is also required in such cases. So what is the crux? Which is that hormone which is playing such important role? That is estrogen, which is available in 3 forms: E2, E1, E3. E2 is most common form of circulating estrogen, that is estradiol. 2 other forms which are less abundant are estrone and estrol. And E2 is principally synthesized by ovary, corpus luteum, and placenta, but there are other extragonadal sites also where it is playing a very important role. And estrogen plays a very important role in cardiovascular disease, like decrease in fibrinolysis, stimulation of angiogenesis, vasodilatation, increased level of nitric oxide, enhancement of mitochondrial function, and reduction of oxidative stress. So there are 4 parameters which is written, that is protective role of estrogen. A loss of ovarian hormone with menopause lead to increase in LDL, triglyceride, and low level of HDL, and high rise of angiotensinogen. So these are all the stages of reproductive stages. I think we should spend more time with reproductive physiology if we want to understand CAD in females in a better way. There are so many stages: regular menstrual cycle, then subtle changes, then it becomes menstrual cycle of variable length, where it becomes perimenopausal, where cycle lengths are irregular, and patient develops vasomotor symptoms in the form of hot flushes, anxiety, depression. Then finally it goes to menopause transition, and how these cycles becomes regular to irregular and delayed, and finally menopause, when even after 12 months there is no menstrual cycle and the hormone level changes. Estrogen level, then see, you should devote more time, we should on FSH level, and on the antral follicle count, where there's a loss of follicle count, inhibin B level, and finally AMH. This is very important hormone, that anti-Mullerian hormone, AMH, which is a sort of biomarker of reproductive aging. This is highly underutilized, and the low level of AMH is a signal that patient will have estrogen deficiency and patient is high risk of CAD in future event. So this is like a menarche, then reproductive life, then it is a menopausal transition, perimenopausal, then postmenopausal, and then remaining lifespan without the cover of protective cover of hormones, especially estrogen. So MT, that is menopause transition, is one important point, and the age, early the menopause, the higher risk of CAD and high risk of osteoporosis and so many problems which come under package. So early MT is almost equal to CAD equivalent in females, and I think it should be given more importance and recognition, so to better understand the complexity of CAD in females. So menopause transition, remember, it is risk independent of chronological age. Early menopause transition has relative risk of 1.38 versus surgical menopause, where relative risk is 4.55%. 40% life is still in early menopause phases, and this leads to increased sympathetic nervous activity, oxidative stress, fibrosis, high level of angiotensinogen, and inflammatory marker. Latest guidelines did not incorporate early MT as a risk factor for CVT. So menopause transition, once it completely changes the internal milieu of the body of female in the form of endogenous changes, endogenous sex hormone, unfavorable changes in body fat distribution, weight gain, lipid, lipoprotein, and which are as a structural and functional measures of blood vessel health during MT period. There's decreased endothelium function, dysfunction is there, ED is definitely there, decreased level of NO is there, and decreased brachial artery vasodilatation has been demonstrated. And most common risk factors CVD in menopausal women are central obesity, atherogenic dyslipidemia, glucose intolerance, and hypertension. So this early menopause transition dependent on race also, depends on ethnicity also, shorter cycle, high parity, cigarette smoking, alcohol, drugs, and one is genetic factor, complex genetic trait, which genome-wide association studies have shown high level of heritability that ranges from 31 to 87%. There's so many common genetic loci which implicate various potential genes across multiple molecular pathways. And this age of menopause transition and CAD risk are inversely related. It leads to increased stiffening of vasculature, increased inflammation, and surgical menopause is associated with greater degree of atherosclerosis. So this is the crux, and that's why we say that is 10-year hormonal protection, 10-year hormonal protection lost once female achieve menopause. So CAD in women lags behind male by 10 years, and increase in MI and sudden death in female lags behind male by 20 years. This is only because of cardioprotective effect of estrogen, and genome-wide association studies have shown that a deleterious effect of immune function, ovarian and neuroendocrine function, impaired DNA repair, and this leads to vasomotor symptom and so many other somatic effects, and finally can lead to over CAD. So that's why I came into picture hormone replacement therapy, which was very widely discussed a few years back, that why not we should give hormone. There were so many studies, Hers study was there, that whether we should give hormones or not. But most of these studies found that hormone replacement therapy was controversial, where they will start giving 0.625 milligram of estrogen and 10 milligram of progesterone, especially uterus was there in patients of menopause to control vasomotor symptoms and those who are high risk of CAD, but didn't translate into beneficial effect on future CAD events or vascular events. So it has become controversial, and I don't think it is no popular. In selected cases, it may be considered, but it has been associated with high level of triglyceride level. high level of clotting factor, which lead to DVT, high inflammatory levels are there. And that's why they have been controversial, because all these hormones which were given post-menopausal group didn't translate into positive effect. This has been seen in HERS-1, HERS-2 trial. This has been seen in raloxifene and selective estrogen receptor modulator also. And especially if it is oral delivery, because of first pass liver metabolism, so many unfavorable effects are there. Transdermal E2 delivery is slightly better, because it is devoid of increase in clotting factor, inflammatory markers, and does not lead to increase in triglyceride or LDL. But still, more studies are required, more maturity is required, more randomized trials are required to see how HRT is protective for future cardiovascular event in postmenopausal women. Until now, we should take it with suspicion, and selected cases we can discuss with gynecologists or obstetrician, and don't advise as a blanket cover for all postmenopausal women. Then another category of women who are having this ACS is young females that Minoca or Inoca, that is without obstructive CAD. It is not a single disease, require evaluation to make diagnosis and exclude non-coronary etiology of MI. Non-coronary causes can be supply-demand mismatch, Takotsubo cardiomyopathy, which mimics, although it is not related to CAD, cardiomyopathy, so myocarditis, and coronary causes of menocardial plaque erosion or rupture, coronary vasospasm, microvascular dysfunction, coronary embolism, thrombus, or spontaneous coronary artery dissection, which is especially seen in active reproductive period, which can present as ACS. So Menoca is also not a benign disease, and Menoca is also having 6 to 10% mortality over a period of time. So Menoca requires to be confirmed. What is the cause of Menoca? So many inflammatory markers, of prothrombotic screen tests are required. Look for etiology. What was type of MI? Type 1, 2, 3, 4, plaque description, dissection, spasm, vasospasm, or thromboembolism, cardiac MRI to rule out myocarditis with late gadolinium enhancement. Sometimes TE to rule out cardiomyolism. We have to look for left atrial appendage and imaging to look whether it was plaque rupture, erosion, or dissection. So this is, or sometimes theoretical, that academic point is testing for coronary vasospasm. So prevalence in the absence of obstructive CAD is 5 to 6%. Women with ACS are twice as likely to have normal angiogram or demonstrate no obstructive CAD when compared to male, and they don't have such a benign prognosis. All-cause mortality appear to be lower in Menoca as compared to MI with obstructive CAD, but still not benign. To date, there are no prospective randomized control type management of these. Most of them are managed. We have to first identify what is the cause of Menoca and manage. Most of the time it has to manage medically only. A spontaneous dissection is very important, interesting picture, especially when the hormones are active, high level of estrogen is there, and pregnant females. Sometimes I have seen 2 or 3 cases where pregnant female develop ACS, and this is because of formation of intramural hematoma, which encroaches through coronary lumen. Most of the time, it is left as such, because conservatively it has to be managed. We have to avoid stenting in these cases unless it is flow limiting. So there are 3 types of this spontaneous coronary artery dissection. Type 1, typical appearance, multiple lumen, arterial wall stain. Type 2, most common. Type 3 is mimic atherosclerosis. The most common cover ST elevation pregnant women. So thrombolysis is not recommended in that period. Urgent angiography has to be performed for suspected dissection for those presenting with ST elevated MI. Risk of iatrogenic dissection higher with radial approach. The femoral approach must be preferred in pregnant female. So this is one case where she was a 35-year-old, and she was having 3 months amenorrhea pregnancy, and she developed a chest pain and cough, and she was highly suspected of this dissection. It was non-flow limiting as well managed conservatively. Then passing reference on Takotsubo cardiomyopathy, which is associated with the acute stress cardiomyopathy. Still, it is also more common in female, which has so many names like transient LV apical ballooning syndrome. It is also considered as a form of Menoca in the absence of obstructive CAD and should not be considered subtype, but it has a specific pathophysiology that likely reflects neurocardiogenic myocardial stenting. So incidence is rising. Per year, pregnancy prevalence is higher in women, particularly postmenopausal, and female sex is one of the 7 parameter of diagnostic score. There's always episode of physical or psychological stress, and they have active history of neurological, psychological disorder, and ECG mimics ACS. That's why we should be aware of this etiology. So this is about the Minoka, and I don't want to sound more theoretical and go on a talk about cardiomyopathy. But we see what are the difference between angiographic pattern of pre and post menopausal movement. Pre, there is plaque erosion, is most common cause, and postmenopausal we can get all the side type pattern of coronary angiographic pattern, and plaque rupture is most common. Pre-LAD is the most common, single vesicle disease is more common, and Janssen scores are much lower as compared to postmenopausal, which have high Janssen score, which has TVD, and pre have less fibrosis, less calcium, less collateral. Postmenopausal have more fibrosis, type C lesion, more collateral. Cumulative event rate was 1.7 times higher in postmenopausal age group than in premenopausal. So we mean to say that is the scenario is more complex in postmenopausal. But interestingly, in our thesis, which are we are doing nowadays, we find many cases out of 60. There are many 10, 15 cases are very complex, even in the female of 30, 35-year-old female. So optical medical therapy of women with CAD does not differ from that of men. Women receive less intensive treatment because psychosocial factor, bias, delayed reporting to the hospital, inappropriate medical treatment, poor follow-up, and poor cardiac rehabilitation compared to male. And somewhat, there's one paper showed that the response is different to ACE inhibitor and beta blockers also, and they are more frail, the high bleeding risk, especially with glycoprotein 2 inhibitor, and short-term mortality may be as equal to male or it may be higher in female. Their response outcome is inferior as compared to male counterpart with similar ACS. So, Swed Heart study included every hospital system in Sweden in 2003 and 13 demonstrated excessive mortality related to underuse of guideline-indicated therapy in those women with STEMI and STEMI compared with male after adjusting with age for age and comorbidities. So, this has been seen there is sex and racial differences in not just medical therapy but also in interventional therapy. Persistence and disparity in reperfusion and revascularization therapies after STEM in women, resulting in in-hospital higher mortality compared to male, women and higher overall in-hospital mortality than compared to male, and incomplete revascularization, female tolerate poorly as compared to male. So this has to be done. If there is TVT, we have to open the arteries, short sequence of time. So they are incompletely revascularized as twice as likely as male to have repeat MI or die from causes even after adjusting for this. So autopsy research has demonstrated coronary artery lesion in young women contain less calcium as compared to male older women. And coronary plaque of young complementary fatty deposits that are easy to rupture cause acute thrombosis due to cardiovascular disease. So this is the thesis which we are nowadays for the last year my PGDM student is undertaking. This is a clinical etiological and angiographic profile of premenopausal. We have selected this group and aims and objective are we have to see the clinical etiological profile, angiographic pattern, and short-term hospital outcome. So till now we have done around 65 cases, and most of the cases have been seen in 46, 50 years, followed by 41, 45 years, but there are 3 patients in 25, 30 years also, and 2 or 3 were APLA positive in this group. So you can see that is young female, the 3 or even 7, below 35, there are almost 10 females who reported with STEM ACS. Then mean duration of pain was 13 hours, range was 30 to 32 hours, and character atypical in 57, typical of 43% of cases. Then distribution risk factor hypertensive, 36 were hypertensive, 29 were normotensive. Diabetes mellitus as per ADA guideline, after 65, 40 were diabetic. After 65, 53 were having thyroid disorder in the form of hypothyroid, 12 were euthyroid. Dyslipidemia, especially high TGL, LDL, 58 were dyslipidemic and 7 were having normal lipid profile. And after 65, 52 were having high BMI, they were obese. History of substance abuse, especially smoking. Yes, out of 65, 42 were having history of smoking and 32 were tobacco chewers. Family history, positive family history was documented 37 young females and 28 they were having no family history suggestive of CAD. Bad obstetric history was found in 30% female. We have sent serum estimation for estradiol FSH level. FSH level films that it starts rising during perimenopause and postmenopause, which leads to dyslipidemia, and serum estradiol starts coming down. Estimation of AMH, we have to take help of some specialized lab. In selected cases, we are sending sample, and we will see what are the values of AMH, anti-Mullerian hormone, whether it can serve as a marker of reproductive aging in selected cases. History of anxiety depression is quite common. Out of 65-40% having anxiety and depression. And novel risk factor serum, homocysteine was found in 83% cases, ApoB high 66, ApoB APO1 ratio ranging 70%, high LDL 57, HSCRP very high, 91% cases, and APLA was positive in 4% in 4 patients out of 65, 4 patients. So this was a presentation. 24 as STEMI, and 23 were anastomie, 10 had unstable angina, 8 had chronic stable angina, and this is a pattern of ACS. That is anterior wall MI, inferior wall MI, posterior extension, anterolateral wall MI, inferior wall with RV extension. This is a pattern of ECG-wise or correlative angiography. This was a pattern which was found. Non-obstructive atherosclerosis found in 10 patients. Single vessel disease usually LAD was found in 25. Double vessel disease 15. Triple vessel disease 10. Left main, including other association found in 5 cases. So see, this is, I'm talking about perimenopausal. And perimenopausal, we found out of 65, even 10 had triple vessel disease, and 5 have left main, and 15 has DVT. So I think it is not such a number which can be ignored, and which has been seen and mentioned in literature. It is not so simple. I think scenario has been changing. So LAD was found in 42% cases as a single vessel disease, RCA 26, LC 21%, and type of lesion of type A 28, type B 14, and type C 8, that is percentage was 50, 25, 14% respectively. Treatment giving medical treatment 42%, angioplasty, and CBG was advised 10. I don't know how many went and followed the advisor CBG, but there were 10 patients. They're on medical treatment. Most of them are doing well also. Uneventful in 53, developed complication, and expired 3 patients expired in short-term follow-up. The way forward is latest to 2011 AHA guideline of CVD prevention in women did not incorporate menopause transition as a CVD risk factor. So there is a compelling need to discuss the implication of accumulating body of literature on menopause transition and CVD risk. As perimenopause is a time of significant daily cardiovascular changes, new research may focus on estimating when women will pass this stage. AMH, I think it should be better utilized. More studies should be done with the emerging biomarker, which can help us include, and it can be correlated with, combined with what is the serum estrogen and serum FSH level. The result of using this new biomarker should supplement or complement data gained from other more traditional hormone measurement like estrogen and FSH. Prevention of cardiovascular disease should begin early in men and women. For women, consultation during perimenopausal and menopausal period are ideal opportunity to assess cardiovascular risk. Early menopause is generally referred as superior risk for CVD, and this factor should be strong warning sign during medical consultation. Literature supporting critical role for time of initiation of hormonal therapy use relative to menopause with initiation less than 60 years age, within 10 years of menopause appear to associate with reduced CVD risk. Strongly call for further research whether we can better utilize hormone replacement therapy for many more patients. Till now, I think it is controversial and it is having its own increasing problem. Data for primary and secondary prevention of atherosclerosis, CVD, and improved survival with lipid level intervention remains elusive for women, and further studies required for evidence-based recommendation to be developed specifically for women. So, CV complication, stroke risk, ASA and American Stroke Association recommends CVD risk assessment as specific risk factors related to bad obstetric history. More research is required to study female as a group as mortality is high. Is hormonal factor overrated, or risk factor, traditional risk factor and novel risk factor dominate over clinical scenario? Because what I find with the help of all these cases, and I think you all must have seen in cath lab, witness rising CD even in young women with most complex angiographic pattern and significant morbidity and mortality. Young women also, we find numbers increasing, although they are less as compared to young males. But as compared to previous decade, young women, they are more coming in number with ACS presentation, and many times most of the risk factors are absent, and angiographic pattern is quite complex, and patient is also quite sick or critical. So I think we should shed our bias and we should do research on a special subgroup. And it always a wise idea to study CAD group wise, elderly group, postmenopausal, premenopausal, young male, and we get many facets of many new points to better understand the disease. So more knowledge of reproductive physiology and collaboration with the specialties of endo, gynae, ops, and basic sciences is required. Thank you.
Thank you, Dr. Asif, for that excellent deliberation. I will request Ajay's comments before I put something, and I will invite my other gentlemen to have their voice. Ajay?
Right. So actually very comprehensive presentation. I think he's covered it extensively. One place I think where we have a good scope for intervention is women who have developed gestational diabetes and pregnancy-induced hypertension.
Yeah.
Because these are high-risk patients, and we know that they are going to be at high risk in future. And if we intervene in these, it can make a very big difference. And I think a large number of women who would develop cardiovascular disease before the age of, let us say, 55, 60, would either have one of these two conditions. The only issue is that interventions in this period is very difficult because the women are busy in bringing up their children and they lose the motivation. But I think this is one important group which we should identify and really target them.
Yeah. This has been mentioned that they are very important to gestation, diabetes, hypertension, and bad obstetric history and early menopause. And these 4 points should not be missed. And because we take very casually all these points. What is your take on hormone replacement therapy? Because I discuss even with my gynecologist here in department, and most of them they give only for this vaso to control vasomotor symptoms in perimenopause. For CAD, we have to take this.
Ajay, you go ahead. Go ahead, Ajay.
No, so I don't think it is being used very frequently now. I mean, it's very rarely being used and only in patients with very refractory symptoms.
Yeah.
So please.
But then we have a meta-analysis on the safety part, because all the older data, I don't think we can depend on the observational data and the WISE data, the WHI data. All of them has cautioned us about the observational data set. They are excellent in cardioprotection, but when it came to RCTs, it was not showing. But a meta-analysis, which is possibly near similar to an RCT, suggested that if you are starting it for even for cardioprotection in the initial 10 years of menopause, you can be, especially with the transdermal part, there is no excess cardiovascular mortality. That was one of the main concerns. The only thing they suggested was there was an excess risk of carcinoma breast, not excess cardiovascular mortality. So I think we are changing our thoughts on I think MIT, the hormone treatment is showing way back, not like the earlier data. And especially with the, as you said, AMH estimation and other things, newer biomarkers estimation, if it helps us to identify the groups of people who will benefit, definitely, I am very positive in that the hormonal therapy will be back.
Yeah.
But then you have to be few things I wanted to comment on that the ESC in 2021 came out with an extensive article on menopause and cardiovascular disease. So we have data. We have data which suggested, which have now incorporated importance into the perimenopausal and the postmenopausal women, and the very many cardiovascular. They did not confine just to coronary artery disease. They were extensively talking about the very many cardiovascular. So this is a very interesting area. And possibly, Smit, and I thought we have data. I can honestly say the only 3 publication or 4 publication from India about ACS or coronary artery disease in India, I mean, in women, has come from two from our sector, and one there is a registry called the DMAT registry published many years ago. 1,500 patients, 340 women. That was the one which showed that there is no difference in the mortality. The mortality are increased because of the confounders, the delayed presentation, the multiple risk factors, the non-receipt of the guideline directed medical. That is the reason why women has a higher mortality. They don't have a system in there. It's not there. They're not vulnerable for a high mortality. We make them vulnerable because of the poor treatment that we are giving.
Yeah.
We published two data. One is the Kerala ICS registry, 25,000 patients, 6,000 women data. There was a paper published in the Global Heart, 2015, but then we were in our only 15% under coronary angiography. We never bothered to analyze any of things. But we also showed that there is no difference in the mortality in ACS in women. ACS in women present more with NSTEMI rather than STEMI. And we have no opportunity to analyze their the CAG or angioplasty, because at that particular time, there were only 12 cath labs in Kerala. But come in 2015, we have another study of 21,000 patients in the largest randomized controlled trial, I will say ACS QUIC. That analysis was from Middlesex, one group on Middlesex. They showed that there could be a higher mortality in the woman.
Yeah.
Which has been shared by the NCDR data. If you look at the ACC NCDR data, the NCDR showed there is an excess mortality, excess heart failure, everything is excess in women. But then they were not very, very sure about, because there were no proper randomized control. So my submission to Smit, you're the big boss around Smit. Let us begin our research with CAD or ACS or heart failure in women. Concentrate on women. We have absolutely positive the data. The only angiographic data, you have a wonderful data of 65 patients now. Asif, I will request you to write it up properly. We have a published data from Chennai. Nambirajan has published. He compared a pre-menopausal woman CAD ACS with post-menopausal woman CAD ACS. About 50 patients from premenopausal and 140 patient postmenopausal. It was published in some unknown journal. I don't know. I have it. I can send it to you. And it showed, basically, as you said, SCAD is more common in the premenopausal woman, but in the elderly postmenopausal woman, it is as complex as in any other way. There is no difference. There is no difference in men and women when it comes to 3-vessel disease or two-vessel disease or LM disease. So basically, we have to gather data, and this possibly is the best area where we can begin our research.
Yeah.
Yeah. So, sir, the reason why yourself and Dr. Sastry were made a expert panel here was with the idea that you'll pick up this and you'll start because you have taken up the research part of PGI cardiology alumni.
Oh, Budapa hai bhai, but then we want youngsters like Asif, Ajay, and you to be on the hem. Now we need principal coordinators. We can give you everything. We can give you the pro forma. We can give you all the necessary, because most of them are available already. But we need our youngsters, maybe about 25, 30 people to cope. We should get a sizable number.
Yeah.
That is very, very important. And Asif could be, he can spearhead that. Ajay can do that.
Yes.
We will do that, Smit.
Sir.
I think Smith has put up something on phytoestrogen. So would you like to comment on phytoestrogen? I'm not aware of much data on phytoestrogen and how it compares to normal estrogen.
Yeah, I only know there are 3 types of estradiol, even E2, E3, and E2 is more important.
Yes.
I don't know. I've
also.
not been. So, but then one point again, I want to stress on, Asif, is even though smoking is definitely on the increase amongst our young females. Now you have seen it. We have all seen it, and the GAT survey showed 20%. India is the second country in the world after USA in women smoking prevalence. So we are going bad. And importantly, the fossil fuels and the atmospheric pollution that our women have
Yeah, definitely.
is a substantial. Unfortunately, there is no work done, and I don't know whether we can do anything on that. We can except we can ask them, are they using fossil fuel or what is their cooking habits? But that is another very neglected area. So when we do the study, I think we will take everything in hand and come out with some performer with every one of you can contribute, and that will be my take on that, Smit.
Yeah.
Yes.
Sure.
So actually, pollution is something that is really under considered, especially air pollution. And now there are reports that in carotid stenosis, the plaques contain microplastics.
Yeah.
So the plastics actually present in plaques in the carotid. So that's an
Nanoplastic.
area that we need to work on.
Yeah. Right.
Actually, what I found interesting to present here is that is around 15 out of 65, they're very complex disease. Without risk factor, they were 30, 32 or 34-year females. So I think even in this scenario is changing. I think because of those factors are so much dominating in young females that it has already crossed or dominated so-called hormone protection. Because the diffuse disease, long disease, not everyone was having simple single vessel disease. And you must have also experienced that young females are also coming more complex pattern, which was, I think, was not in earlier decade. The last 10 years, some changes have been seen in this group also.
Sir,
So
it is
we are recruiting more patients and see what is the angiographic pattern. It is quite complex, even in young women.
in our experience in Chhattisgarh, it is not smoking, but there is something called gudaku, which is a combination of jaggery and tobacco, good and tamaku. So it is used as a mouth, paste, dental paste, and that is considered to be very hygienic. And the females do it 5 or 7 times a day. So whenever you have anything to eat, and then it will be followed by putting it on finger and brushing the teeth. And I have found that under 35, the commonest cause for MI in female is gudaku. They will have a history of gudaku.
And it has tobacco leaves or what?
It is if you see how it is made, sir, it is made, there are rooms where they spread tobacco leaves and put jaggery over it. The heat melts the jaggery, and then they ask people to, walk over that. So it becomes chunks into a paste, and that is packed, and that is exported even to Gulf and other places.
Oh.
It's a very it fetches good money. It's a huge business here. So a tamaku gudaku factory owner would be making somewhere around 25 to 30 lakhs a day.
No.
So a very interesting area. I think all these can be involved in that, and whatever we are planning.
My impression was that females have, unstable angina and non-ST elevations MI, but your study had STMI maximum in females.
I mean, in India, almost I think 37%, and basically those were the times when the concept of unstable angina was very prominent when we did it in 2006-7. Later, but when we did it in 2015, we did not involve unstable angina and found out that STEMI is more common than in both in males and females. So
I think that is also a transition, sir. Probably we were having more worse disease. It's less spasmodic or that reactive kind of thing. It has become more of atherosclerotic.
Basically, because as you have shown in your data also, the prevalence of the incidence of hypertension in the postmenopausal women is something like 40%, 50%, much more than in men. Dyslipidemia changes over the perimenopausal period. So endothelial function changes. So many reasons for them to become susceptible for development of pruritus. So once the estrogen saga is over, it makes them very vulnerable.
Very, very.
one more my myth shattered is that HDL is not protective in female. I used to think that HDL would be, HDL is never high in male, but definitely we find that HDL is good, high in female. But now you're suggesting that it is not protective.
Not protective. HDL always has this complicated correlation. And although 10 milligram was higher as compared to male, but it was not shown beneficial. And high HDL can be hazardous also, very high HDL. So it is somewhat very complicated particle, and its relation with CAD is very complicated. A very high HDL is as bad as high LDL. It's slightly at that level.
HDL is possibly the most sophisticated and unknown, quote unknown. We don't know anything about it.
Don't know.
And sir, homocysteine is totally out.
The problem with homocysteine is now we know it may have some temporal relationship, but then bringing down homocysteine doesn't give us any outcome benefit. That is our problem. So you can say that you can estimate homocysteine, find out, and possibly try to bring it down. But then we have nothing in our hand which gives us an outcome result. That is our problem. LPA is a different baby. Now we have more and more data. LPA reduction will definitely help with the newer molecules coming up, even though we are not using it right now. But then I am disappointed with homocysteine while I am positive with LPA.
And there is always some patient may be suffering from SLE or vasculitis, which are totally unaware. They can also push towards CAD, vasculitis, SLE, pregnancy-related complication, unless we do complete panel, which patient may not afford, which is the only point of academic interest. Ideally, in young females, if there's no clue, they should look for anti-double-stranded DNA, ANA, very high titer, where pregnancy usually is associated with mild rise in homocysteine. So it has to be 2 or 3 to 4 times raised only to say whether clinically significant. So we should not forget vasculitis syndrome. So many female are suffering from that silently.
Yes. There's a hypothesis that Kawasaki disease in childhood might predispose to CAD. Of course, it's never been proved, but that is one of the hypotheses.
Yeah.
The bad obstetric history is only the gestational diabetes or gestational hypertension, or it also includes obstetric bad history also?
It has, whatever I have read in last 1 week, everything: placental insufficiency, IUGR, fetal complication. Even if mother is not having, but fetus is having, then also that mother in future is at risk. That is also written. And abortions and that ovarian insufficiency, everything is bad obstetric history. Eclampsia related gestational diabetes, whether it is later converted into totally manifested over diabetes or not. Gestational can change, it may not change, but even that episode of gestational diabetes is also important for future CAD. A patient repeated pregnancy and every time she is having gestational diabetes, then also it cannot be ignored. So the literature says that.
Thank you, sir.
It is very wonderful to see Dr. Sir, my favorite sir, Dr. Ajay and Mohan sir, and very enlightening talk, Dr. Smit. So actually, I wanted to present next time. Smith will give me time. Then after 2-3 months, at the one thesis on LA cardiopathy in heart failure with preserved ejection fraction. Our thesis is on LA cardiopathy. That is what we are missing is we don't understand the function of left atrium, and we have to understand left atrium to understand preserved ejection fraction. So with the help of MRI, NT-proBNP, and that is strain echo. So next time, whenever Smith gives me time,
whenever you want, sir, it's your forum. It's
so,
nothing.
So that it is also interesting. The LA cardiopathy and our that candidate who got the second award, Sky Thesis Award, All India basis, she was awarded second prize. So I want to present that thesis next time, whenever.
Sure, sir. Whenever you wish.
Okay.
So, in fact, it is Saujatya now who's taken over. Unfortunately,
Yeah.
Today, otherwise he would have done
He's
it.
doing good work. He's doing just teamwork with you.
Sir.
So,
So
Smit,
I think-
what I will suggest is now we will get hold of BKS also. I will call him. I have called him before prior to your meeting there, and told him that we will do whatever the association, I mean, or the committee, our group decides. But then possibly we have not thought about it further. Let us begin from today, and let us ask Asif and Ajay and whoever you want to involve. Let us form a group of researchers. And this could be the beginning, a CAD in women or SES or heart. I mean, whatever we can discuss on one of these occasions. And let us not ponder over it too for long. Some beginning is always better always. And
take a step.
we have to
Yeah.
find out who are the investigators and what should be the best way. We need some funding. So all these things can be worked out. With whatever limited experience we had, we can share you what is the best way to go forward.
Yeah.
Definitely. Looking forward. Right, sir? Then
Thank
And
you.
people
Thank
like
you.
Ajay,
Thank you,
we have,
Smit, for nine. Thank you, Asif.
people
Thank you,
like
sir.
Ajay who have years and years of experience in research.
Awesome. And thank you, Asif. That was
Thank you, sir.
fantastic, very
Thank you.
comprehensive presentation.
Thank you, sir. Thank you all.
Thank you. Thank you. Thank you.
Okay, good night. Bye.
Good night, sir. Good night. Good night. Good night.